common misconception that I hear is that we're trying to expedite their death. Certainly we have our own medical ethics, but Ohio law does not support euthanasia. We're not accepting people into hospice in order to expedite their death. We're trying to give them a chance to process, and we want to help them be comfortable, and we want to support both them and the families through the process.
Well, hello, everybody. This is Wendy Gericke. I am the community liaison for CHP Home Care and Hospice. We decided to kind of have a light, casual, informal conversation with two of our docs that help us with hospice. And today we have Dr. Beth Besaw and Dr. Kevin Park with us. And we're just going to kind of, go over some questions that I think a lot of people ask when it comes to hospice and a lot of things that people don't know about. Dr. Park, could you tell us we'll start with you. Tell us your connection with CHP.
I began practice in the area in 1992 in Bryan, Ohio and Montpelier after a 3-year military commitment. And shortly after starting in practice, Dr. Nicholas Walls, who was the director of the hospital hospice program, invited me to be his deputy director or assistant director of hospice. And so I began in service as a hospice director, medical director for the hospital, which later kind of stopped their service after some time. And CHP, which had been under another name, I think it was Hospice the Caring Way, if I'm not mistaken, or Hospice of Williams and Fulton County, and then changed its name to CHP. It was an easy transition for me at that time. It was approximately, I'm going to guess, between 10 and 15 years ago. And they changed their name to CHP at that point. It's really been something that is part of my DNA, if you will, dealing with people that are in the end-of-life care and that kind of thing. So I really feel at home working for hospice.
Well, we're very glad to have you. How about you, Dr. Besaw? How did you...
I started late in my career. I was 42 before I finished residency, and then it wasn't too long after that CHP was trying to build the inpatient center, and I was just involved peripherally with them raising funds for that because I just thought it was a wonderful idea. And then I always had my own patients as a primary care doctor. If my patients were going to be on hospice, I still wanted to follow them and be involved with them and still visit them, even though they were on hospice and or at the inpatient center. So then when a few years ago, when they were looking for someone to be a director in Defiance, they asked me, I had retired from the office, and they asked if I wanted to help out, which I was more than happy to. And then now I do Defiance inpatient, and Paulding County.
I wondered if we could start with maybe the top 3 myths or myth busters that you guys would like to discuss when it comes to hospice. What comes to mind that people get wrong all the time when it comes to,
I guess one thing is that they think you have to be at death's door to get to contact hospice. And many people who have a terminal illness and have decided to forego any more treatments, it's okay, even if you're still feeling pretty good, to get involved, and they can just help you on the journey, not wait till the end.
Mm-hmm. I've heard a lot of people they wait too long to get started into hospice. Another one that when I was out, marketing was people think the word hospice means you have to go somewhere. It doesn't mean hospice is wherever you call home. Is that correct, do you think?
Yes.
Mm-hmm. So when patients come to you, Dr. Park, do they, and they're or maybe their families, what is one of the first things they say to you, or one of the first questions that they're just worried about when it comes to their loved ones?
I think many of them are contemplating just how much time they have with their loved one. We have general principles on when we admit people to hospice. We think of it as a 6-month estimate of time remaining, but it's not a strict code according to medical science. It's more of a guesstimation based on their underlying diagnosis, their functionality, and generally how they're doing with intake and that kind of thing. We address early on, I think another misconception they have is that we as the physicians know exactly how much time they have, and that's conjecture. We can go by their physical signs and how they look and their vital signs and the like, but we certainly don't have the secret to life from the standpoint of knowing when it's going to end for them. We just have experience, and we have a sense by evaluating them and looking at them and hearing about their history about a general estimate of how much time they have. Mm-hmm. The other common misconception that I hear is that we're trying to expedite their death. Certainly we have our own medical ethics, but Ohio law does not support euthanasia. We're not accepting people into hospice in order to expedite their death. We're trying to give them a chance to process, and we want to help them be comfortable, and we want to support both them and the families through the process.
What does hospice look like, day to day when it comes to the patients and even the families' days?
Well, I think it can drag on when it comes to, just the expression of pain and having, tremendous pain, horrific pain is something that people want some relief from. And the concept that hospice can help alleviate that and give them some comfort during the process that's going on is helpful to know. So that's our goal. Our goal is to maximize comfort without expediting the end of life, and to support them through the philosophy and the religious part of it, the Christian faith part of it from my standpoint, and to give them support through pastoral or social work services and in addition to home health aides and that kind of thing. Mm-hmm. So there's a lot that goes on. There are a lot of different people. CHP, who we work for, has multiple different avenues of assistance, including things such as home health aides to help with bathing and what have you, but also massage and music and different other things, including a social service person who can aid in transitions, or a pastoral assistance to help them answer questions about the meaning of life and death issues. So,
another thing I think is great that we have is that, we support the whole family too. It's not just the patient, which I think a lot of people don't know. It's important because even after the patient's passed, is that correct? That it's,
yes.
We're there to, mm-hmm.
Yes. And you can keep coming back year after year if you want. Mm-hmm. And they still provide emotional support for the families. Mm-hmm. And the other thing they do, a lot of people think that it's like once you get hospice, they're going to be in the home with you the whole time. And so that's another misconception is some people think, well, they don't realize they have to have somebody there with the patient. It's not 24 hours a day. Mm-hmm. So the family still has to bear the brunt of that support and care for the patient. But they have all kinds of avenues to help them with that. And they do have access to people to give them a break now and then, mm-hmm. and which is really important, because if it goes for very long, you can get really burnt out and exhausted, and then the caregiver's health goes too.
Caregiver burnout's a big thing. You're right. Yeah. And so speaking to that, when we said hospice is wherever that can be, wherever a patient calls home, that's key. But also, we do have a wonderful inpatient if and when the patients need to. Mm-hmm.
And I will say that I have many, especially towards the end when it really becomes overwhelming for the family to see their loved one suffering, and some people just don't want their their loved one to die at their house.
Yeah.
And it's so much of a relief to them to have them, and it's such a lovely facility, and the people there are
They're
so
next level.
kind
I
and-
know.
yes,
If
yes,
I
and-
every time I'm out, people are they get so tearful telling me how wonderful, the place is.
And that was even though I had followed when I was still in private practice, I would follow my patients, but then when my twin sister was out there, and the kindness that they showed to her meant a lot to me.
Yeah. And there's respite care. Explain that to me.
Yeah, respite care is it's when the caregiver can get the patient can get a 5-day stay at the inpatient, so that the family can rest and regroup, or if they have an event coming up, sometimes they have a family wedding out of state, and the patient isn't going to be able to attend, and they don't want to. They don't have anyone who can stay with them, then they can arrange for that respite care. And it's generally for 5 days, and they're treated like gold at the inpatient center.
They really are.
Yeah.
Yeah. Well, you know what I always like to bring up? I think it's very interesting that Jimmy Carter started on hospice. Well, he was on hospice for 2 years. I find that really interesting. And you spoke to the point that you can get on and off hospice, but the myth is that you can't get, once you're on, you're on. So let's talk about that briefly.
We look at each patient every 2 weeks at our interdepartmental team meetings. We call it IDT for short. And we look at how they're doing, each patient, and how they're progressing. And if they're progressing towards death, and if they're improving and or they're thriving, then at that point we ask the question, does this person need to be on hospice? And I think that's the bottom line there. I'm certain there are governmental regulations or thought processes that go along with how CHP has their own policies that back that up. But we tend to think that if someone is thriving, then they may not need hospice at that point, or they don't need the assistance of regular nursing staff and the like. So people do turn around, sometimes renal failure and pneumonias or respiratory failure after pneumonias will turn around and people will improve. And sometimes they're able to improve enough that they can be, we laughingly call it graduation from hospice, meaning they get off. And that's, it can be a personal decision by the patient or their family, but it also can be related to the CHP staff and the interdepartmental team that decides that they no longer need hospice.
Do you have any, we probably can't pull out any statistics right now because we didn't prepare you for this question, but people that get on hospice earlier rather than the last week before, do they tend to obviously live longer, do you think? If they
live longer than someone who comes
well, obviously, I know it's kind of a dumb
Yeah.
question in a way, but you know what I mean by the
because,
whole.
I mean, because I had a patient that had bladder cancer, and she was declining, but very slowly over a long time, and I think it was about 2 years. But we could demonstrate that she was still, she still had the same diagnosis, and then she did just gradually get worse and then pass. But we didn't consider graduating her from hospice because she wasn't getting better.
Yeah.
But there are those that do. So
Yeah, but also she was so comfortable, and she was made. Well, she was comfortable, so she my opinion is that I think she probably lived longer because she got on it sooner, rather than waiting. So a lot of people hospice is such a scary word. I think people are like, I don't want mom or dad to go into hospice because that's it. That's the end. And, now what? So I think that if we kind of let people know that it's something that they need to not be so afraid of, start earlier, it may or may not extend their life a little, is what I was kind of, I don't know if I'm right.
Well,
you guys are the experts.
Yeah, I think sometimes when we get their pain controlled, that they're able to really have some quality of life, so to speak. And once their pain's better controlled and they're getting the support services they need, that sometimes they do thrive for a little while, or they're able to make adjustments to the process that's going on because they have the assistance they need. So it's not uncommon for people to get a little bit better once they first start hospice, but then as the disease, if it's cancer or heart disease and it's progressing, then it usually does. So
That's another thing too. Once they get the pain controlled or and the other symptoms that they have, the shortness of breath or whatever, sometimes they're able to do a family event, do a family trip, something that they all have memories of, and that I think maybe wouldn't happen if they didn't have hospice involved to help them get those symptoms controlled.
It's very true. Dr. Park, you were telling me a story the other day. Could you tell everybody what you were saying?
I had a patient that we were following for several months on hospice, and she had COPD. And as you know, COPD is a chronic obstructive lung disease pattern that becomes severe at some point after years of smoking. That's the main cause of it anyway. And those patients are very short of breath, and their quality of life is diminished by that shortness of breath. And as I became somewhat closer to that patient over a period of time, for going to their house periodically for recertification, face-to-face visits, I started to sense that, she was becoming somewhat emotional about the process and that she needed some spiritual guidance or what have you. That day, it seemed like she was approaching death within a couple, 3 weeks, probably because of the amount of medicine that we were giving her to try to help her with that shortness of breath. She was tearful that day, and I said, you know what, if you'll let me, may I pray for you? And I wasn't certain that how she would respond, but something happened that I didn't expect. She bowed her head right there, and it's like, if I don't respond right now, it's like my words are empty. So I began to pray with her, grabbed her hand and prayed with her for a minute or two. And I think there was a connection that we had that day that helped her, and it helped me too. It helped me grow some in my faith and helped me grow some in my willingness to kind of step out and do something I hadn't done much in my career. But it was worthwhile for both of us, I think.
Any other topics about hospice and our, CHP Home Care and Hospice, we are very comprehensive. So I think when people hear CHP Home Care and Hospice, they stop at the word hospice and just want to briefly say that we do everything. I can't think of anything that an adult day center, home care, and I know we're focusing on hospice right now, but we do a lot of different things that, I think help patients in a great deal that a lot of other companies don't. I just have to point that out.
I think I'd like to add, too, that DIP, Defiance Inpatient Center for hospice for CHP, has some specific things that we think about that they might be able to do that you might not be able to do as easily at home, including what we would call parenteral or therapy and medication standpoint that's going either through the sub-Q space or IV, what have you, so that people that have pain that's out of control, we're able to maximize the medications in a more concentrated way if they can't take it orally, that kind of thing. So people who have symptoms that just can't seem to be controlled at home, DIP tends to be a great place for them. The other thing I'll mention that from my own experience too, Beth, you mentioned that too. My father-in-law died there, and the concept of having the support of having family be able to come there and visit and hang out while the spouse stays there as long as they need to or feel led or compelled to stay with their spouse, they can. It's in a country-like setting. It's very quiet. The support staff there are very caring, as you mentioned, and I think perform in an outstanding fashion. So this is an opportunity for those that where the the situation seems to be a little bit out of control at home, either from the standpoint of severe pain or occasionally people get anxious, that's anxiety becomes severe, or even agitation that goes along with the dying process. Sometimes it's better to be in a place like that. So we think of it, and I was thinking about this from the standpoint of what you were talking about. We have birthing experiences. We talk about the mother designing how she wants her birthing experience and where she wants it, et cetera. I think people are becoming more readily open about describing where and how they want to die and that process and who they want to be there. I think DIP offers that a little bit more than a lot of places. So
Yeah. Well, before we wrap it up, is if someone is even starting to wonder if hospice might be, the right decision, how does someone get started? What's the next step?
Well, you just call out to the hospice center for each county. They each have one, and they can evaluate, and they will make arrangements. They'll get your medical records, and they will make arrangements to discuss with the family and the patient what's involved. Discuss inpatient or home, and then they will also provide a tour of the inpatient center if the family would like, and the inpatient or the input people are also the same people that you're going to see.
Same people, which is really helpful, right?
And they have a special vocation to be involved in this. Yeah,
We try to make it simple, not too complicated at all, right? And we do free assessments. I know too. That if you're not sure, I know that we do a free assessment, so you can go out and a nurse will come out and assess. So, well,
I would add to that I think your primary care physician or provider, nurse practitioner, should be open to the concept of asking you as a patient whether you are ready for that kind of thing. And usually that comes when either stage 4 cancer that spread to bone or brain or something along that line, or the physician of record, attending physician, sees that the patient is not doing well from a functional standpoint, not eating well, is going to need a feeding tube or something more aggressive, or even IV fluids, that kind of thing. The primary care provider's role is to be the advocate for the patient and not necessarily always to fight. If we send a patient with stage 4 disease to a cancer doctor, most of them are going to want to keep fighting cancer. Your primary care doctor wants to know what you want to do. We need to let our patients give them a chance to ask that question and interact with their families and decide if that indeed is where they want to go with things. It's a philosophical difference. It's an acceptance, if you will, of what the process is going to take place, and enabling the patient and family members to experience that at a less aggressive fashion. I know the state of Ohio is entertaining the whole concept of whether chemotherapy can be given during hospice and that kind of thing. That's a tough question. We could talk about that for a long time.
That could be the next one, the next episode.
Yeah. And we may want to cover that going forward. The code status, DNRs, those are very complicated things for people to understand, and what the difference between a DNR status and a durable power of attorney for health care and a living will, all those documents that people kind of get confused.
You get the deer in the headlight looks when you haven't had them done, right?
So it might be a good idea to talk about those maybe next time.
Okay. Well, we really appreciate you, being on the show today, and thank you for coming on.
Thank you.
Thank you, Wendy.